So we know heart failure is a very significant challenge for everybody. There's over 5 million patients diagnosed in the United States with heart failure. It's really one of the most common reasons why people are admitted to the hospital. Huge impact on hospital resources. 300,000 people die per year of heart failure. And we've done a great job in other aspects of cardiovascular disease, lowering incidence, for example, coronary artery disease. But as we're keeping patients alive who have comorbidities like coronary artery disease, congenital heart disease, valvular heart disease, sort of the final common pathway is the development of congestive heart failure. So as our population is aging as well, the incidence of heart failure is actually increasing, unlike other areas of cardiovascular disease. And the amount of money we spend on caring for patients with heart failure is significant. So over 5% of healthcare dollars go to this one diagnosis. So we have a lot of opportunity here to have a positive impact, both to the individual patient and then on a greater level to the society. So this is a comparison of the mortality with several different conditions. So when you say the word cancer to a patient or a patient's family, they understand that generally the prognosis is poor. They take it very seriously. But when you say you have heart failure to a patient or a patient's family, they really have no idea what that means. So if you look at the mortality at 1 year of patients with end-stage heart failure who are on optimal medical management, that's the bar to the far right, the red bar, you can see the prognosis is very poor, similar to patients who have lung cancer or pancreatic cancer. So our job as clinicians is to let patients know where they are in their disease process and learn to present them treatment options a little earlier, because often we ourselves don't have good understanding of where they are in their disease process and we delay treatments. And as we touched on earlier in the previous talk, if we can get to people a little earlier when they don't come crashing and burning in cardiogenic shock, we have the potential to have a much better outcome over the long term. So when I'm talking with my colleagues in different areas and referring cardiologists, you can give all this data about, how do you risk stratify heart failure patients? But I usually, they say, look, I'm busy. I see, so many patients a day. With all different diagnoses in cardiology, just can you boil it down to the key points? What do I have to look for? So I always show this slide, which is the red flag risk factors for increased mortality in patients with advanced heart failure. So if you see these things, these are the patients that we want to see in the advanced heart failure program. So patients who are unable to take neurohormonal antagonists or beta blockers. So you'll hear, the patient's dizzy or bradycardic, so we had to cut down the beta blockers, or renal function is deteriorating, so we had to hold ACE inhibitors or ARBs. So if you have to stop or decrease doses of these kinds of medications, that is a very bad prognostic indicator for the patient. So even if they're looking pretty good, the fact that you're cutting back on optimal medical management, that is a red flag that patient may need to see an advanced heart failure program. Patients who need inotropes. So if patients get admitted and they're requiring inotropes to get them diuresed, those are people we want to see. So they may or may not turn out to be candidates for advanced heart failure therapy, but once you need inotropes to support cardiac function, you're in the end stages of your disease. The cardiorenal syndrome. So especially on general medicine and hospitalist service, we'll see patients, we'll get consulted where someone comes in massively volume overloaded, they start to get IV diuretics, the creatinine bumps up, they hold the diuretics and maybe even give fluid back. I think that's a scenario we've all encountered. So when the patient's massively volume overloaded and you give a diuretic, which is the appropriate treatment, but it's at the expense of renal function, that means the cardiac output to the kidneys is poor. And so when we see that again is that red flag that something more needs to be done. A patient who needs escalating diuretic doses. So if you had a patient that's been stable on a diuretic for a certain period of time and all of a sudden they're getting more and more easily volume overloaded and you have to keep pumping up the diuretics, diuretic dose by itself, the higher the dose, we know that's an independent predictor of patients not doing well. The frequent flyers, so the people that keep bouncing in and out of the hospital. So sometimes we attribute this to certain things like they're not taking their medications correctly or they're eating out and eating high sodium foods. So there may be things that we can write it off to, but for somebody who keeps bouncing in and out, we need to pay a lot of attention to that patient. There may be modifiable factors, but it may be a sign that their cardiomyopathy is advancing. If you see hyponatremia, especially if you are on neurohormonal blockade and you see hyponatremia in the lab work, again, that's an independent predictor of poor outcome. Poor nutritional status, so the concept of cardiac cachexia. So here in the South, that can be difficult to assess because you can be obese by weight, yet not be nutritionally sound. So we actually make it a habit to follow prealbumin, and if we start seeing prealbumin going down, we have patients with very low prealbumin that weigh 300 pounds. So we know that they're hiding cardiac cachexia under all that insulation. And then patients whose ICD starts going off, so if you put in an ICD for primary prophylaxis and it starts going off because you're developing ventricular arrhythmias, that means your substrate is changing, your cardiomyopathy is advancing. So those are people we want to see as well. Again, this was alluded to by our previous speaker. So, if we see someone with advanced heart failure, poor systolic function, we've tried optimal medical management and they're failing, why can't we just transplant everybody? Because we know long-term outcomes are pretty good. Well, unfortunately, we're in the world where we have very limited donor supply. And so if you look at this graph from the ISHLT, North America is in the green bars, and you can see really from the 1990s to almost the present day, a pretty flat line. So we do about 2,500 adult heart transplants in the United States per year, and despite all the campaigns we have about organ donation and all that, we really have not really been able to increase the number of donor organs available. So ventricular assist devices. What if a patient presents acutely with cardiogenic shock, and even if they may be a transplant candidate, we don't know how long they'll have to wait for an organ? What do we? When is the donor organ going to be available? We don't know. What if the patient is not a candidate for a heart transplant, but they're in the end stages of disease? What do we have to offer? So this is where mechanical circulatory support comes in to use and is used to support the failing heart. So there's certain terminology that's associated with VADs, and I just want to touch on it because people throw these terms around. So the first is bridge to transplantation. So we can use VADs in patients with end-stage heart failure who are listed for a heart transplant. We don't feel that they're going to be stable enough to wait for an appropriate amount of time for a donor organ to be available, so we use the VAD to bridge them to a successful transplant. This gives the patient the opportunity to spend time out of the hospital, to work on their rehab, their nutritional status, reverse any end organ dysfunction they may have, so that when they go into transplant eventually, they have the best chance of doing well after surgery. The second category is the newer designation. Really, we've had destination therapy over the last 10 years or so. So these are patients who are not transplant candidates, who have end-stage disease, where we can use mechanical circulatory support as a permanent treatment. They're not going to be getting a heart transplant. And then I throw in this third category, bridge to candidacy, just because people will talk about it. So if someone comes acutely ill, we don't know what direction things are going to go in down the line. They may get good enough to have a heart transplant. They may not. They may have to stay on a device. We talk about bridge to candidacy. When we as clinicians have to determine the reason we're putting in a device, we do not use this terminology anymore. It's not really recognized, especially by third-party payers. So we as clinicians have to get out the crystal ball and make a prediction about where we think the patient's going to go and decide whether it's going to be destination or a bridge to transplant. So any VAD has really same basic features. So, if you think about a car, whether it's a Lexus, whether it's a Mercedes, whether it's a Toyota, whether it's a Ford, it has the same basic components. So there's obviously a pump. The pump is implanted. There has to be some kind of software that's controlling the pump function. So you can see on this gentleman's belt, that white thing is the controller. And then there has to be a power source because it's a motor. So through the abdominal wall, a drive line exits, hooks up to the controller, and then hooks up to the batteries. So when the patient's ambulatory, they wear their battery pack. It's all underneath clothing. You usually can't even tell looking at the patient that they have a VAD. And then if they're at home, they actually plug into a unit at home where they get power at night when they're resting and sleeping. So really, whatever device we talk about, there are some nuances in the different types of devices, but it's all really a variation of this. These are currently the FDA approved devices, and these are all what we call continuous flow. So if you think about the heart empties and pumps, it's pulsatile. When VADs first came out in the late 80s and early 90s, the device technology was pulsatile. So there was a chamber within the pump itself, and it filled and emptied with blood, and it pumped just like the heart did. And these were great devices. They worked very well, but they did not have long-term longevity. So these weren't devices that lasted 5 years, 10 years. So about a decade ago, these continuous flow devices became FDA approved, and these devices continuously pump blood through the circulation. So there's no systole and diastole. Blood is constantly flowing through the system. And they are either based on an axial flow design, which is where the impeller or whatever's pushing the blood, spinning the blood, is on a horizontal axis, or they are a centrifugal pump where the impeller is on a vertical axis. So the first device is the Heartware device. The second device is the HeartMate 2, which is the axial. You can see it's a horizontal configuration. And then the HeartMate 3, which is the newer iteration, which is interestingly a centrifugal pump, similar to the Heartware. So these are all FDA-approved devices. Right now, they all require full anticoagulation with warfarin and antiplatelet therapy. And they're all approved, but for different indications. The Heartware you can use as a bridge to transplant or as destination therapy. Same with the HeartMate 2, but currently HeartMate 3 is only approved as a bridge to transplant. So, we have to get the patients through surgery. So here this doctor is saying, we got you through the surgery fine, but I regret to say some of your insurance coverage didn't make it. So there's a lot of things we have to think about before we send somebody for an operation. So I'm going to touch on some of the factors that we as VAD clinicians look at before we decide to send someone for surgery. This is a really difficult process for obviously the patient, because they know that they're facing their mortality, the family. They often want everything done for the patient, and then also for the team. I always say we're in the VAD business. I love putting VADs in people, but we only love to do it if we think the patient's going to succeed, because getting an LVAD and then not making it is a very bad way to go. So we're not helping anybody when we do that. So we have to be very responsible to the patient, and sometimes not doing an operation is the right thing. So the evaluation process is really critical in deciding whether to proceed with a VAD. So one of the things we look at is overall frailty. So another one of the things I always say is a VAD doesn't make you 25 again. So sometimes people have a perception that if I get a VAD, I'm going to be like I was, 30 years ago, and that's not the case. So frailty is one of the parameters that we look at, and it can be really, really hard to assess this. So this is just a small study, and it really illustrated the point that I wanted to make. So these are just 40 patients where they had 20 that were frail and 21 that were not. And they looked and saw how they did after surgery. And the way they assessed frailty was how patient reported exhaustion, grip strength, mobility, their appetite, and their ability to do physical activity, self-reported. And you can see the patients after LVAD with the blue line who were not frail did significantly better than the patients who had frailty going into surgery. So we definitely don't want to see frailty. If you look in a multivariable analysis at some of the factors that predicted poor outcome after VAD surgery, if you went in intubated, if you needed a BiVAD, these were factors that portended a poor prognosis. The other thing we pay a lot of attention to is renal failure. So this again, a small study, but kind of made the point, so this is why I'm showing it. The top red line was outcome after LVAD surgery on patients who did not require dialysis after surgery, and the blue line below it is the outcome for patients who required dialysis. So these are not patients who were on dialysis prior, because generally we don't take those patients for a VAD. These were people who developed renal failure requiring dialysis after surgery. And you can see dialysis and a VAD are a very, very bad combination as far as survival. So we pay a lot of attention to renal function. Some of the other risk factors for not doing well in a multivariable analysis there to the right, and this was mentioned in the last talk, if you have evidence of RV dysfunction, so if you have a lot of tricuspid regurgitation, if you required tricuspid valve repair in surgery, obviously if your GFR was low, low, and if your MELD score, which is a reflection of your liver function, if you had a high MELD score, you did not do well. So we really pay a lot of attention to end organ function. So the critical factors in outcome are not just identifying who needs a VAD, because I think, we can always say this patient is very sick, so that's easy to identify. But the hard part is identifying who's going to do well after surgery. What degree of their impairments are reversible? And that's the there's a science, but there's an art, and that's where the art of this comes in. So as cardiologists, we tend to be very focused on hemodynamics, so we have to shift our focus. So as cardiologists, we have to stop not just focusing on hemodynamics, but looking at markers of end organ function that help us in our decision making. So that is kind of our process when we're evaluating somebody. Let's now assume the patient's gotten a VAD. What are some of our long-term limitations as far as morbidity and mortality? So these are really the Achilles heels of VAD therapy. And, when we all went into this, with continuous devices 10 plus years ago, we didn't know what the long-term outcomes were going to be like, but we now know that these are the things that are the main limiters of how patients do. So number one is infection. It was mentioned earlier today that you have a drive line, there's a break in the skin, that's a permanent break in the skin, that's a potential source of infection. So right now we don't have a completely implantable device where there's no break in the skin. So infection is a very, very serious thing that we always look out for. These patients have to be anticoagulated. So anticoagulation has pluses and minuses. So bleeding and clotting are the two things we're always fighting against. And what can happen is actually both in the same patient. So we'll have patients who are thrombosing their VAD, but having a GI bleed at the same time. So it can be very challenging to manage the anticoagulation for these patients. So GI bleeds, there's a high incidence of GI bleeds in these patients. Continuous flow is different than pulsatile flow. Pulsatile flow is physiologic. That's how we all function. But continuous flow is different. Our system, wasn't naturally designed for that. So there are physiologic implications. So one of them is to the GI tract. There's a high propensity for AV malformations to occur. And so GI bleeding can be a significant source, usually not of mortality, but more of morbidity. So getting readmitted, requiring multiple blood transfusions. Stroke is a very feared complication, and strokes can either be thromboembolic or hemorrhagic. Again, we're always fighting. And again, it can sometimes be both. You can have a ischemic stroke, a thromboembolic stroke that converts into a hemorrhagic stroke. Again, as I said, a VAD doesn't make you younger. You're still susceptible to all the other things that can occur with aging. So you can have comorbidities that naturally will progress. You may develop new diseases. So especially in patients with destination VAD who are going to be on these devices for many years, we've had patients who've developed new cancers and new other problems that were not there at the time of the implant, and now they have an LVAD. So that means as LVAD clinicians, we have to collaborate with many other different specialists in order to treat the patient's other comorbidities. And there are very significant lifestyle modifications. So you cannot submerge yourself in water. We have to teach you how to take a shower. We have to teach you how to look after your drive line. You have to come back to the medical center very frequently. We're going to be in your life for the rest of your life. So we think about it as a medical family. And so just like any family, there's some family members you love to be around and other family members that are kind of, that old aunt or uncle that, you have to see at Thanksgiving. Well, we can't just see them at Thanksgiving. We have to see them all the time. And so, you have to learn to deal with dealing with people like, long term. You're going to see them forever. So there are challenges in that. So let's talk a little bit more about specific outcomes. I want to touch on mortality after VAD, morbidity. It's very important to look at patient-based outcome measures now. So when you present data to the FDA, they don't just want to know about if the patient survives, they want to know how patients feel. So you're required to collect patient-based outcome data. And then how have outcomes changed over the last decade? So this is a poor patient who's trying to be grieved for, and someone keeps bothering them on the phone. So I've got to go, I'm dying. So mortality. So this is some, again, data from INTERMACS. And for those of you who don't know, INTERMACS was a data registry for pretty much all patients who received mechanical circulatory support over the last decade. Any center that did DT therapy was mandated to participate. So it was a wonderful idea because as this technology proliferated, we all had to contribute data. So we learned a lot about it as we were actually doing it. So I think there's very few therapies where they have had such a prospective view about data collection. So if you look at the top two lines, the blue and the red, let's focus on that for a second. Those are LVADs. So if the first era is from 2008 to 2012, that's the blue line. And then the red line is the more recent era, 2013 to 2016. And you can see, I've drawn a little arrow there at the top at 24 months. You can see survival is about 75%. So you remember that first slide I showed where mortality was 75%. Now we've switched that to survival being 75%. So we can have a tremendous impact on survival, but it's not perfect therapy. You can see as the line goes down, there are patients that now can survive years on these devices. So this is data all the way out to 72 months, which many of these people would not have been expected to live a year. And this is just a competing outcomes analysis. So for patients who received an LVAD as a bridge to cardiac transplantation, what happens to them at 1 year? So over half the patients are alive with the device in place. About a third of patients get transplanted. So you can see even though it's put in as a bridge, it's still a challenge to get a heart transplant. So only about a third gets transplanted. About 12% don't make it a year. And then we always observe a 1% to 2% recovery. So where there's improvement in LV function that allows explant of the device. So with the newer technology, which is the HeartMate 3 device that's just come out here in the last few years compared to the previous, the HeartMate 2. So this is data from the HeartMate 3 trial where they were comparing the two pumps. And the upper blue line is the HeartMate 3. And you can see at 12 months, there's been some incremental improvements in outcome, which are sustained out to 2 years. So it looks like as technology improves, we can make further positive impacts on survival. So let's now switch gears from mortality and talk a little bit about morbidity. So we don't try not to say this. We got your test results back, read it and weep. So, we try to do a little better as far as communication. So one of the dreaded things that can happen is stroke, as I mentioned. So intracranial hemorrhage can be devastating. This is a paper that was published recently. It's a series of patients, and we contributed patients to this series looking at the outcomes in 59 patients who had VAD therapy who developed intracranial hemorrhage. And hemorrhage can be, like in the far left panel, subdural hemorrhage, subarachnoid hemorrhage, and then intraparenchymal hemorrhage. So it can be any presentation. When you're admitted with an intracranial hemorrhage, your mortality on that admission is 40%, above 40%. So it's very significant, the mortality. The average INR in this series was 2.8. So on warfarin therapy, our usual target INR is between 2 and 3. So this was in the therapeutic range. But there was a wide range, patients from all the way from 1.2, really not anticoagulated, all the way to up to almost 7. If you had the presence of midline shift, large intracranial hemorrhage size, and a poor Glasgow Coma scale, those patients, it portended a poorer prognosis. So those patients tended not to do well. So again, this illustrates when these people come in, we have to collaborate very closely with our neurosurgeons and work with them on whether a surgical approach to any of these issues is warranted, how we're going to monitor the patient, and how we're going to manage the anticoagulation perioperatively. If you just look at overall stroke rates, so including ischemic stroke, this is again comparing HeartMate 3, which is the newer device, to the HeartMate 2. And you can see on the top line, the centrifugal pump, which is the HeartMate 3, the incidence of stroke or the freedom from stroke was much better than with the HeartMate 2. So actually the FDA pays a lot of attention to this now because we know stroke is such a devastating consequence if it happens. And so it seems like newer devices do have lower stroke rates, but not something that we've been able to eliminate. I touched on GI bleeding earlier, so you can see this is data here at our center that at 3 years, almost 50%, so the blue line goes, freedom from. So half the patients have had some kind of a GI bleeding event. So it's extremely common. And often what we'll see is a certain patient has a very high propensity. So one patient will have multiple GI bleeding events. The risk of that, the hazard, which is the lower red line, in the immediate post-op period, you're at the highest risk of developing a GI bleed. The risk goes down, but you can see it's a flat, continuous line. So even if you're far out from your surgery, you're still always at risk of developing GI bleeding. Freedom from pump thrombosis. So when a pump develops a blood clot inside and compromises pump function, that often means another surgery for the patient. They have to go back to the OR and have the pump exchanged. So when we see this, we don't like it, and obviously the patient doesn't like it. So again, this is newer data showing that the HeartMate 3 has a lower incidence of pump thrombosis, very low incidence actually compared to the centrifugal pump. This was a really big story in the last few years because, as VAD clinicians got more comfortable managing patients with continuous flow, we got a little looser with our anticoagulation requirements. We thought maybe we could run INRs lower. Everybody was kind of doing their own thing as far as anticoagulation protocols. And we realized when we started seeing high rates of pump thrombosis that wasn't a good approach, and we had to have a more standardized approach across centers as far as how we anticoagulate patients. So this kind of looks at all the different complications, the morbidities, infection, right heart failure, neurologic events, device malfunction, and multi-organ system failure. And these are hazards, so risks of developing these as contributors to mortality. And you can see in the early postoperative period, risks are high. As time goes down, they do decrease, but you can see that they're sustained over the life of the patient on device. And if you extend the line out, so if you can see at the bottom right where it goes all the way out to 96 months, you can see multi-organ failure, risk starts to go up, infection, risk starts to go up. So these patients are never free of these complications. So we, as the VAD team, have to be constantly monitoring to make sure that they're not developing these complications. So here at UAB, we actually have a protocol where we see the patients every month in clinic for the entire time that they're on a VAD. So there's patients that have been on VADs for 7 and 8 years. We see them every month for the entire time that they're on an LVAD in an effort to avoid these complications. And when we see things we're concerned about, jump on top of them. So if you just look at the overall incidence of what patients die from on an LVAD, the most common event is a neurological event, followed by multi-organ failure, patients who decide to withdraw support, infections, and then other complications. So let's switch over to patient-based outcome. So everybody wants a mood elevator, right? So zippity-doo-dah. So this is actually an area that has had a lot of attention and focus. And like I say, for the FDA, they want to see that we don't want to just keep people alive on machines. We want to actually make sure that we have positive impacts on quality of life. We are also required to discuss, when we discuss consent with the patient for surgery, we don't just discuss survival. We have to obviously do that, but we actually are required to document that we've discussed quality of life impact, what is their expectation after VAD surgery as far as quality of life. We have to document that that's been discussed with the patient. So we take this part very seriously. So if you look at pre-implant to post-implant, and this is broken out again by eras, but you can see actually between the two bars, it's pretty much the same. So the pre is to the left of the dotted line where patients report about self-care, and the tool used here is the EQ, the EuroQual. And when they talk about self-care pre-VAD, they have severe problems, over a third, 40% have severe problems. After surgery, you can see the amount of red goes down. So they still report some problems, but overall, much better as far as their ability to do self-care. For usual activities, again, before 50% of the patients report severe problems with doing usual activities. That goes down significantly. The EQ5 visual analog scale, so this is like a thermometer where you just draw a line as far as where you feel. 0 is the worst, 100 is the best. You can see before LVAD to the left that their EuroQual is 30, and then it goes up 60 to 70. So significant improvements in just how they feel overall. Really, the ultimate question is, are you glad you had an LVAD? I mean, at the end of the day, that's what the patients need to acknowledge, and you can see 80% plus report that they are glad that they proceeded with LVAD. So just some final thoughts. So mechanical circulatory support really flips survival. So we saw mortality is very high. We turn that number into a survival. And these are really in patients who are appropriately selected, and I touched on that, and I think that's a very key part of what we do as VAD clinicians, is finding the patients that will benefit the most. Survival is quite good across the currently available devices, but maybe some improvements with the newer devices that are available. And the theme this morning, we know the therapy is still imperfect. There's a lot of things we still have to improve upon. There's still significant morbidity, but patients generally are willing to accept those risks so that they can survive. Patients do experience robust improvements in quality of life, and hopefully as technology continues to improve, we're going to be able to mitigate some of these long-term limitations of mechanical circulatory support.